patients with adult congenital heart disease, some of them are complex, need to be seen by a specialist in adult congenital heart disease. The Houston Methodist system, they collaborate with us on so many areas, and particularly for areas of adult congenital heart disease, the primary care physicians as well as the adult cardiologists.
Good evening. Welcome. I'm Huey Lin with the Houston Methodist Adult Congenital Heart Program, and we are celebrating Day 3 of Houston Methodist Adult Congenital Heart Awareness Week. This has been a fantastic week full of really exciting material, and as always tonight we have a great topic in which we're going to be talking about acquired heart disease in adults with congenital heart disease. And as always, this is a very interactive session, and we would love to have your participation in the form of questions and comments. So if you'd like to participate, please log on to pollev, that's pollev.com, and enter in DeBakey, that's D-E-B-A-K-E-Y, and then send in your questions. If you'd like to use your phone instead, you can text D-E-B-A-K-E-Y to the number 37607, and that'll be on the screen throughout, so we can talk about that some more, and we'd love to have your questions. As with all of our events this week, continuing education credits are available for nurses. This is your link to get there. And then as well, we also have continuing medical education for our physicians, and this is your link to get there. And then we also have a QR code. And then finally, of course, on Saturday, we will have our annual Adult Congenital Heart Symposium. Once you've registered and once you've evaluated the activity, you can print and download your certificate in PDF format. We are looking for all of you to join us in events like these. We are looking for patients and families to join us for our Educational Advisory Board, not only to join us in the studio here to discuss your topic of interest, but also to participate in our advisory board so you can help us to shape the way we do patient-centered education in adult congenital heart disease here at Houston Methodist. And then finally, we were recently funded by the Patient-Centered Outcomes Research Institute to form a stakeholder roundtable to design and come up with research topics along the lines of patient-centered outcomes research in adult congenital heart disease here in this region. Not only in Houston, but in Texas and the surrounding region. So if you're interested, send us an email to scachdcollaborative@houstonmethodist.org. We really need your help, so join us. And so, without further ado, let's get into tonight's event. So, sitting to my right is Tammy Loyd, our esteemed guest who has 23 years of experience in nursing, including the pediatric CV ICU. And she's going to be talking to us a lot about her experiences with congenital heart disease as well as acquired heart disease and how that's affected us. And then to her right is Dr. Khurram Nasir, who is the Director of Preventive Cardiology here at Houston Methodist. He and I began this conversation about a year and a half ago about how we can start to talk about how we're going to better care for acquired heart disease and prevent acquired heart disease in our patients with congenital heart disease. So to start us off, Tammy, why don't you tell us a little bit about your story from the beginning, and we're going to have a really great time talking about how we can address acquired heart disease and congenital heart disease.
Well, most of my heart problems are heredity, and my family does have a very extensive congenital. My sister has heart disease, had heart surgery when she was 7. I was diagnosed with Turner's at 12, but I have a coarc, and I wasn't even diagnosed with that till I was 50 something. So it was kind of strange to find that out when I had been taking care of these kids when they were little and been with parents when their kids were diagnosed with it. From there, my problems have been a lot with the acquired heart disease. I've got a stent, and then recently was just diagnosed with a penetrating aortic ulcer, which had no idea I had. So it's been an interesting course. Luckily, we have such a great hospital here and great doctors that look at these things and know what to do, but it's been interesting for me as a nurse, and just seeing these kids, knowing that I was one of those kids, and now the kids I've taken care of, they're going to come into this community. They're going to be part of your health care, your patients, and they're living longer. We're doing much better taking care of them. So I think it's going to be a huge practice for everybody, and we need a lot of people in that practice. I think a lot of people don't even know they have heart disease, and then something happens. Congenital, they were never diagnosed as kids, and something happens, and all of a sudden, did you know you had this? No. I did work in the CVICU for 5 years, and these parents are really traumatized when they find out their child has heart disease. But then again, they are given so much hope now, which was not there 20, 30 years ago.
Yeah, I think what you've pointed out is really something very interesting, which is that we now have the luxury of actually having this conversation about patients developing acquired heart disease in their 4th, 5th, and 6th decades,
Right.
which, say 30, 40 years ago, we didn't even have that luxury. So Dr. Nasir, can you tell us, when you approach a patient with, say, coarctation, what are your concerns about acquired heart disease, and where does that come from?
So to start first, as a coarctation patient myself, I truly want to give a gratitude to the teams of pediatric cardiologists and those who are taking care of adult congenital heart disease. As congenital heart disease patients, we are now living much longer, as you just pointed out, 4th, 5th, 6th, and 7th, and something which is unknown, at least in the developing part of the world. Mm-hmm. However, it also brings in new challenges. One is that the general notion that the patient, you are cured. Whereas we truly know that hemodynamically, structurally, electrophysiology, that's not the case. And most likely than the general population will put you at a slightly acquired risk for acquired heart disease. Now, the evidence is sparse. However, a meta-analysis of almost 69,000 adult congenital heart disease patients as compared to those who don't have it has clearly shown that if you had congenital heart disease, you are at least 2 to 3-fold higher risk of acquiring heart disease, stroke, but more importantly, about 5 times about stroke, about heart failure. Secondly, one of the key things is because of the lack of the longevity in the past, most of the folks wouldn't really think more about preventing acquired heart disease, especially in the 6th and the 7th decade. So the challenge has been more around perceptions, not only among the physicians, but the patients. Now, what's the evidence? So there are few registries. For example, there is a large national registry in Germany about adult congenital heart disease that clearly showed that among individuals who even acquired coronary artery disease, for example, or peripheral arterial disease, who should be on high dose statins or cholesterol medications to lower their risk, or antiplatelets, they were only about 25 to 30% were even considered. A great study in 2018 by Dr. Bhatt from Mass Journal showed that the general recommendations that are used to calculate take into account your risk factors and suggest what is your risk of having a heart attack in the next 10 years, just based on that, individuals with congenital heart disease were at least 50% less likely to be provided the guidelines-directed medical therapy. But again, the issue here is sparse information. So now, what do I do? Whenever I'm fortunate enough to see a patient with congenital heart disease, of course, I do consider them at a much higher risk of premature cardiovascular disease. So initiation of screening at a much early, if you would start that at age 40, most of the time. For the rest, I would start them much earlier, 30, 35. Now, few things definitely help. One is cholesterol screening. The risk of diabetes is slightly higher. It seems to be, at least in the literature, so we definitely look for that. Counseling around smoking, physical activity, so the traditional. But what we are finding that more and more adult congenital heart disease patients, at least in US, have some form of CT testing of the chest, and that can help us identify those who have early premature atherosclerotic disease in their vessels. And as a result, we are much more aggressive, not only looking for early signs that wasn't being considered, but once we find, being more aggressive, or at least considering them as CAD equivalent and starting them on the guidelines directed therapy. So
I'm going to stop you for a second there, because I want to make sure that we sort of talk about the same things, because a lot of times when we're having this conversation, we talk very much about the structural issues in congenital heart disease. So let's stop for a second and talk about ischemic heart disease and atherosclerotic disease and how that happens. So I've put up a classic picture of atherosclerotic disease, and then actually here the thrombus formation or a clot forming. Talk us through how this happens, and then maybe we can start understanding a little bit better why we think that might happen in congenital heart disease.
Again, this is a classic picture that what you have pointed out here around a plaque, maybe a plaque rupture causing an occlusion with the platelet formation. So what we are seeing, at least in the adult congenital, especially for example aortopathies such as coarctation, is with hypertension and some of the hemodynamic changes, it makes most likely the vasculature, and especially the low flow states in the coronaries, increased endothelial damage. So we don't really have a great idea right now about the exact mechanism. However, hypertension, endothelial dysfunction seems to promote more endothelial injury, leading to at the same level of cholesterol, maybe a higher risk of the plaque burden. So we don't see as often plaque rupture. We definitely see incidental findings of individuals having significant disease that they may not even know of. And you're going to see a lot of chest pain syndromes in these patients. In my personal experience, I have yet not seen more of plaque rupture, but I have seen significant distributive long-term early disease, obstructive diseases in this. So early screening is very important. Some of the images will definitely be very helpful in these individuals.
So this brings us to a great place to bring you back into the conversation, Tammy. So remind us how things first started with you. So when you and I first met, I think to Dr. Nasir's point, you were talking about chest pain. So talk to us about that.
I was having fatigue and chest pain and just some dizziness, and just didn't generally not feel well. Generally not feeling well, and the chest pains was what was kind of like, and just some shortness of breath that I had not had before. And when you get screened, they went to my PCP, and then they would start the screening, and then one thing just led to another, and mine actually ended up, we found the coarc at that point. I think they tried to do the echo first. They did the echo, and they were like, we're going to have to move on from there. Yeah. And so we found that. We thought my problems were actually because of the coarc, but actually it was I had a blockage in my left main. Oh. And I was having chest pains and stuff, and so luckily we found I had the symptoms, and I didn't actually have a heart attack, I don't think, at that point. But it was, I could just see I wasn't feeling like myself.
Yeah.
I just knew that something was not right.
So I think this is an amazing sort of correlation between what you've been talking about from the theory standpoint as to what we see in reality. So just to reiterate for everybody, it sounds like from what Dr. Nasir is saying is that we see less of the heart attack type of presentation. So the sudden development of acute chest pain that's potentially life-threatening. We see more of the stable coronary artery disease, which is basically the buildup of the plaque slowly over time, as you see in the picture, without the blood clot happening. And that very much mimics or is identical to what Tammy just described, which is starting to have this chest pain and shortness of breath with exertion in the setting of having congenital heart disease. So, and then I think the second thing that you mentioned that I want to make sure that we get into in a little bit more detail is the effect of the coarctation. So Tammy, how long do you think you knew that you had high blood pressure?
Actually, my pressures were always, when I would be at the doctor, were always in the 120s, 110s. You know, I would say it's probably in my 50s when I started seeing it slowly rising up. Not anything significant, not anything the doctors would even say, okay, you know, you're here, you're in the doctor's office. Let's, you know, that's probably you're just nervous. But then all of a sudden I started seeing some 140s, every now and then some 150s, systolic, and then my diastolic always has been in the 70s. It's always been good, but I would say over probably a 5 to 10 year period, it was just kind of slowly going up.
Okay, and I think that's the interesting point, right? I think there's some thought that there's high blood pressure that's causing this, but I think it's maybe a little bit more than just high blood pressure alone. So there's a lot of thought process these days that coarctation has additional bad effects on the heart and the vasculature as a result of the hormones that get secreted, kind of the fight or flight hormones, and then renin, angiotensin, and aldosterone hormones that get secreted that really start to create some of the problems that you talked about. So in other words, it causes the walls of the vessels to start to thicken. It causes a potential injury of the walls. In addition to just having, and maybe beyond just having effects on blood pressure. What are your thoughts from that standpoint, and what do we know about data? Do we have anything yet?
Very little. You know, what we definitely know impact on the heart wall muscles. Endothelial function definitely is dysregulated now. Is that the primary trigger? It's unknown. But the general hypothesis, and at least within the prevention community, is that we know that in these setting of injuries or higher risk endothelial function, hypertension, what about if we can lower the fuel for the plaque buildup, lipid lowering? When should we start thinking about statin therapy, which we know can also improve endothelial function, reduce vascular inflammation? The question that at least which is unknown right now, what is the right time to initiate statin? Should we wait till the plaque develops? Should we start it in their 20s, 30s, or 35? What effect would it have on the plaque buildup? Would it improve endothelial function? Would it reduce vascular inflammation? And all of those changes. So I think we are in a great time where we are having these conversations, and I'm so excited about the PCORI patient conversation, where I'm sure having those discussions with the patients will bring up all of these ideas that can help all of us, and you especially, to figure out what's important. I myself as a patient wonder all of these questions. What if I would have started my statin at age 20?
Right.
Should I have started? Yes, the blood pressure control has been the prime, but what about reducing vascular inflammation and trying to reduce endothelial function? But those are kind of the issues, I think, so the gaps that exist. What I truly believe is the need to ensure that we are creating local registries and we are able to tap on the information all around, and we can all learn together. But more importantly, getting involved the patients, which you are rightly doing so right now.
Yeah, absolutely. And then let me throw something outrageous to both of you, right? So I think if we think about the biology of how atherosclerosis happens in the coronary arteries, it probably didn't happen in just 5 years, right? So the 5 years that you had high blood pressure, you probably started developing plaque in your coronary arteries before then. So then the question, here's the outrageous question then, right? You've had a coarc your entire life, right? So that's, and then just to clarify, so we're on the same page, a coarc is a narrowing of the descending part, the thoracic aorta. So basically that narrowing causes a decrease in blood flow going through it, or at least causes abnormalities in the fluid dynamics of the blood flow going down to the rest of the aorta. And we think that the reason why that creates such a problem for our patients and causes high blood pressure is not just the narrowing itself, but the fact that the kidneys don't see the blood flow the same way, and because of that, then the kidneys secrete some of these fight or flight response type of hormones that we know can cause damage to the heart and cause damage to the cells that line the walls of the vessels. So here's the outrageous question for both of you then. Would it be outrageous to think about starting to treat kids, so even teenagers, when we know that those fatty streaks start to happen in, say, for example, the aorta or other muscular, vascular arterial beds?
I personally think you might want to consider it because, and also screening if there is a huge family history of cholesterol, and screening these kids for that very early. Because I would say probably what age do you really start screening kids for cholesterol? Maybe 15, 16, if they have obesity,
right.
If they're, that kind of thing. That's when you kind of start looking at it, but I know from a standpoint that I don't really see that many cholesterol tests done. But I have a question for you guys. When we look at my cholesterol levels are normal, but they say they want them lower than normal. And why is that?
I'm gonna send it to the preventive cardiologist across from me.
Well, historically, it's always been about your risk factors. So, like cholesterol's been the most important risk factors for plaque buildup in your heart arteries, like a blocked artery. And not everyone with abnormal cholesterols develop plaque, and vice versa, where the cholesterol levels can be normal and you can still have a lot of plaque, as in your case. However, what we know is that still the fuel that promotes not only the development but the promotion. Now we have extensive, almost 2 to 3 decades of evidence that suggests that if you have either a blocked artery or a prior history of heart disease or at high risk for atherosclerosis, whatever your LDL or the cholesterol level is, if you lower it, you significantly lower the risk of having heart attack. And this becomes specifically true for the most commonly used pill called statins, which we now know that apart from lowering the bad cholesterol, also has some additional beneficial effect on the functioning of the small blood vessels, and hence we were talking about maybe that could be also an answer in coarctation in early childhood, and also reduces vessel inflammation. So, and now we have come to a point that we could get your bad cholesterol as low as 30 or 15, almost at the levels that you were born with, and clearly you can still reduce your risk of having a heart attack or a repeat stroke, or the arteries getting blocked, needing opening them up by 2 to 3-fold less risk. So that's definitely, I think so that was a good advice. I would have done the same.
Yeah.
But I also wondered that I'm sure patients like you would be wondering, my cholesterol is normal, and why do I need to have on a cholesterol?
And that's a great question. I'm really glad you brought that up. Before we get there, though, I want to make it very clear. I'm not advocating that we start treating our teenagers with coarctation with statins. I'm just raising the hypothetical question. Is there something we should do that could be better for our teenagers with coarctation to prevent this sort of thing from happening? And then I wanted to comment on the same statin question, and that is the following. So the other hat that I wear, of course, is I'm an interventional cardiologist. So I actually do stents in patients who are having heart attacks in the middle of the night. And these are emergency situations where the patient can potentially die if we don't get the vessel open. And so what we find, not only in very large clinical trials, is that we can reduce people from dying if we put them on the highest dose statin after they've had a heart attack. And I would say, in addition to seeing it in a clinical trial, I would say that in my own practice, anecdotally, in the hundreds of patients that I've done these stents in, that they come back less frequently with problems from their other vessels, say, the right coronary artery, the left circumflex, or the stenosis that's downstream from the stent that I put it in, from where I put the stent in. Those patients come back less frequently with problems with their coronary arteries when I put them on the maximum dose of statin that they can tolerate and get their LDL to as low as they can possibly be. And that applies even in the scenario when they happen to, just strangely enough, have an LDL that's quote unquote normal when they show up with a heart attack. So I think there's a lot that we still need to understand more about how these statins affect people clinically. I think there's a lot understood from the basic science standpoint, the translational standpoint, but why it actually works and saves lives, I think we're still learning about that. And then I think as we've started to learn, lower is potentially will always be better. I think we're still learning that, but I think that that's going to start to become the mantra sooner or later. So I want to move on a little bit and talk a little bit about aortic disease, because I think, Tammy, you talked a little bit about what had happened to you. Tell us what happened that led us to understand that you had a penetrating aortic ulcer.
I was just actually laying in bed one night, and I just started feeling funny, and then I started feeling, it was just like something like that in my chest. I mean, it was just, I told my husband, of course, my husband's like, get in the car, we're going. So I went to the hospital, and they did I sat in the emergency room like everybody else. They did my troponins and everything, and they were all normal. I was not having a heart attack. So got in the emergency room. They go, okay, well, we're going to be sending you home. You're probably, you're okay. We're going to be sending you home. Then I believe they talked to Dr. Mitchke, and he goes, well, just for grins, let's just do a CT. Next thing I knew, a vascular surgeon was coming to talk to me, and I'm going, oh my God.
Thank goodness for Dr. Mitchke.
Yeah. I mean, and that's when I was just like telling me, you call him, call Dr. Lynn. I'm not doing anything. You call Dr. Lynn, you talk to Dr. Mitchke, you call somebody that knows me. That was my main thing, is that I wanted somebody that knew me. But it was just the pain, and I don't know if the pain had anything to do with the penetrating ulcer. I don't know that it did, but I mean, I had no idea that was there, and it's very evident on the imaging. I've seen it, and I don't ever think it was there before. That's what's weird.
Yeah.
And I never knew, even being a nurse, I never knew that could be caused by the plaque.
So Tammy, how were you treated, and what was the course?
We have just been really CT and CTs and CTs. I felt like I just knew the CT person personally, and we have a relationship now. But no, just a lot of screening. Very glad that we were able just to screen. There was some talk of other things needing to be done, other options, but at this point we decided screening. And just really monitoring, and we went up on my statins.
Okay.
That was the one thing we did, but that was my question going. But you look at this and it's normal, but they weren't 30.
Question for you.
Well, actually, before we go there, can you explain to us what a penetrating aortic ulcer is and how it develops?
I was going to ask. My knowledge regarding within the coarctation is this slightly limited. Wanted to ask actually what's the incidence, and what are really the risk factors, and when you see these patients, what are the remedies for them?
Yeah, so I think that's the real challenge. So let's start with the very simplest thing. So I've put up here, unfortunately it's abbreviated as PAU, but this is a beautiful picture of what we're dealing with. And the concept of the penetrating aortic ulcer, at least most of the time we think is related to, again, that atherosclerotic plaque. And then there's something that happens with the fluid dynamic stresses in the aorta where the flow is abnormal and consistently injures the wall. And then just like with coronary artery disease, where ultimately there's an erosion of the first layer of the wall, and then blood gets underneath it, and then the contents spill out. In coronary arteries, that equals the contents spilling out and causing a clot to happen, and then a heart attack ensues when the clot clogs off the artery. in a penetrating aortic ulcer, and then potentially also an aortic dissection, which is what we got really nervous about with you, is that blood gets underneath the first layer of the vessel wall and potentially can expand the space between the first layer and the second layer of the vessel wall. And then that can get much worse in two ways. Number one, it can potentially go and cause what's called dissection, where the blood flow expands that space and then causes problems with blood flow out of the heart, blood flow into the heart, and then potentially can cause problems with blood flow into the coronary arteries and cause sudden death. So that's why dissection is so concerning, and obviously there's some concern that a penetrating aortic ulcer can be the precursor to a dissection. The other part to that is, of course, an aortic rupture. So you can imagine if that first layer has an injury and you have a thinner layer of the second layer, that the next complication can potentially be a rupture, which is where the blood escapes from the aorta, and that's also a cause for sudden death. So coming back to your original question about coarctation, yeah, I think that is the major concern. And of course, so let's talk about all the things now that we're talking about. So in Tammy's situation, we're dealing with Turner syndrome as a background, which we already know is a risk factor for having abnormalities of the tissue in the vessel wall of not only the arteries, but specifically the aorta. And so in addition to that, we have talked about now multiple times that there are abnormalities in the flow through a coarctation. And when I say that, I mean that there's an increase in the velocity of the blood flow through the aorta, through that narrowing. And what that then causes is these currents that can potentially cause increased injury because that velocity is higher, and increased likelihood of causing a penetrating aortic ulcer. You add to that, and we should probably get into this in a little bit more detail, Tammy, that you have a family history of people who have atherosclerotic plaque and ischemic heart disease, which means that in addition to the risk of the cholesterol issue, which was normal in Tammy's situation, she has a risk of developing atherosclerotic plaque in addition to all these other issues. And so I think, unfortunately, in Tammy's situation, this is the highest risk or the highest risk. And so to think about how we manage this, there's actually been a very great publication that just came out in circulation in the last couple months talking about how we look at penetrating aortic ulcer. And they came up with a really nice algorithm for looking at the size of the penetrating aortic ulcer and then predicting which ones need additional monitoring, which ones need surgical intervention, which ones are going to go on to causing these catastrophic events like dissection and rupture. And so going by, and thankfully that came out right before you had your event, so that helped to guide us. Now that said, patients like you were not in that study, right? So patients with coarctation, patients with Turner syndrome were excluded from that study because it's a whole different risk category. So unfortunately, we can use that as a little bit of a guidance, but it's really not about patients like you. So you mentioned having lots of CT scans. So the reason why you had lots of CT scans instead of saying, well, okay, let's go fix this with surgery or let's fix this with a stent graft is because neither of those seems like a very appealing option in a patient who has the risk factors that you do. So what do I mean by that? Well, so in a patient who has Turner syndrome and coarctation, we already think that you have risk for the fragility of your aorta. And so while some operators would do it, some operators would go ahead and put a stent graft in other words, a self-expanding covered stent inside your aorta that has a fabric covering on it to protect the walls of the aorta from continuously having that injury. Some people would do that. We're not sure necessarily whether that's the best option. So some other people would argue that the best way to treat somebody with your background, which is Turner syndrome plus coarctation, is to have open surgery. Okay, but then I think everybody would agree that none of those options are ideal, and they should only be done when there's a definite risk of things progressing. And so the reason why I bring up that recent paper being very important is that they cleared and clearly demonstrated that there are a group of patients who had a small enough penetrating aortic ulcer that they did not progress. They did not go on to having a dissection or a rupture. So that helped to inform it. Obviously, it's not a precise answer in your situation because you have additional risks. But then by doing the additional imaging and demonstrating that over time the ulcer remains stable, we were able to feel a little bit more comfortable of not picking those less optimal options of putting the covered stent in or having you undergo surgery.
So Dr. Lin, we see bicuspid aortic valve a lot more going hand in hand with coarctation and also alone. How does that change the equation, the risks, and from your perspective, the risk of acquired heart disease?
Yeah, that's a really great question. I think the challenge with bicuspid aortic valve is that there's a massive spectrum, right? So I think even in my own limited experience, anecdotally, we see kids as neonates who are critical with bicuspid aortic stenosis coming out as neonates, right? And then we see those who don't show up with clinical valvular heart disease until they're 80-something, even though they have bicuspid aortic valve. And so I think there's something more to it. Unfortunately, what's happening is we're lumping everybody into this term bicuspid aortic valve, and I don't know that we will fully understand that. And I think what that means is, and you'll have to help me with this, is I think what that means is there's probably some sort of heterogeneity that creates that spectrum from a molecular level, right? So for whether it's genetically predisposed or genetics plus some sort of other factor from the environment, et cetera, prenatally, et cetera. I don't know. But I think that probably also contributes to the secondary effects from acquired heart disease standpoint, whether that's development of an aortopathy and aortic root dilation, ascending aortic dilation, or ischemic heart disease and atherosclerotic disease. What are your thoughts?
In my view, I think so, this whole spectrum of when you look at the entire congenital heart disease, pediatric, adolescent, moving to an adult, I think that as a group, there is definitely now a better need for us to start screening earlier. For example, in my view would be, I would prefer to do atherosclerosis screening at least a decade earlier in these individuals if they didn't have any. Two very simple examples if they didn't have is carotid ultrasound and looking for abdominal, any plaque buildup, and you can even do a chest CT, a non-contrast, which is like a mammogram. The radiation is almost equivalent to a mammogram. I would definitely screen them for their cholesterol, HbA1c, insulin resistant much earlier. If you find any early plaque, any early atherosclerotic disease, definitely much more aggressive early on. The other critical thing is hemodynamic disturbances. Most of them will have hypertension. I tend to ask them to do at least a 2-week home blood pressure monitoring, and most of these individuals may have echocardiograms are going to be out there. So any early sign and organ damage, be it minimal left ventricular hypertrophy, LA dilatation, impaired diastolic dysfunction where their heart's not relaxing as well, we see that more often. I tend to become more aggressive as far as the blood pressure control and trying to make sure that their top numbers are at least less than 130. So in essence, we don't have the best evidence. Within this uncertainty, we are making the best judgment from what we know from the journal community of what works, but trying to apply them at least a decade earlier. So but that's kind of a space where I feel that you and your colleagues all across the country, it's a great place to start working together, and hopefully a lot of preventive cardiologists can come and work with you, because I think that this is one of the most rising population. Now we have more than few million individuals with adult congenital disease. We're living into 40s, 60s, and 70s. But at the same time, we know the risk of acquired heart disease is higher, but we have no best evidence to guide where you and I can sit here and say, this is based on the evidence. We are coming from a place of what we think works the best, but now I think we all need to get together to create that evidence.
Well, I have something to add on that. Because my dad died of an aortic aneurysm at 56. So and when they did the autopsy, he had atherosclerosis everywhere. I mean, it was just everywhere. So at that point, when you have somebody like me that has Turner's, and then I have that family history, I probably should have been screening I mean, I was in my 30s when he died, so my screening should have started then.
Yeah.
They should have had me on screening, but, you know, I didn't feel, I was 30-something. I felt good, you know.
I will be honest with you. I mean, from a humbly, I want to submit that 15 years ago, I'm not sure we knew
anything. Exactly.
Back then. I would say a lot of the things that we're now talking about probably happened in the last 5-7 years.
Yeah.
You know, so I think, you know, this is a rapidly evolving area. I mean, I think, you know, having adults with congenital heart disease entering into their 5th, 6th decade is a new thing, right? I mean, we didn't know what to do with these people back then. But let me stop for a second and make sure we answer some of these questions. So are there any medical breakthroughs around the corner for ACHD? So I'll take that one. So I think there's been a lot of really great developments as far as some of the stents, like we talked about. So the covered stent. So these are basically, let me just make sure we talk about this. So covered stents are basically, a stent is a wire mesh tube that allows us to have structure within a vessel. And then a covered stent basically has some sort of fabric on it, like Dacron or nylon. I say that because that was the original fabric that DeBakey used, or Gore-Tex, so that way it protects the vessel wall from continuously being injured and forms a new vessel. So there is a lot of really interesting technology developing from that standpoint. And then likewise, there's been some really interesting work from some of my colleagues to develop a stent that will actually dissolve over time. So you can implant that stent in a child's coarctation, and then it will dissolve, so that way you're not limited by the size of the stent when the kid grows up. So you can, and of course, that the vessel will be left uncovered by a stent in the future. And then there's a second question here. What is the highest risk factor that is the easiest to minimize? I think I'll direct that to Dr. Nasir.
Well, in my humble personal as well as the patient, I think so it's truly the blood pressure. The issue that, of course, I'm not well aware, of course, the literature evolves continuously so much, and most of them, it's either based on the Marfan's or aortopathy, and we keep on swinging back between ACE inhibitors and beta blocker, a combination, losartan. Of course, no conclusive evidence which works best, but a combination of ARB plus beta blocker seems to be the most ideal, as long as we keep the blood pressure as low as possible. Of course, not having those spikes, but we're going to still see the pulse pressures being on the higher side for most of these individuals. I don't have the best answer for that, but I think that from my perspective, anyone with these aortopathies or hemodynamically challenging early atherosclerotic disease, early screening and trying to lower the cholesterol will play a huge role, at least as far as atherosclerosis, blocking of the arteries, causing stable heart disease, and even some evidence suggesting that reducing the risk of aneurysm development with reduction in the vascular inflammation. So those would be the two main ones, but now we have more advancements in even heart failure prevention. New therapies which for the first time are showing are like statins for the heart failure, a new class that were initially developed to manage diabetes, the SGLT2I inhibitors that have impact on the structure. So I think we are in very exciting times where we don't have the answers, but shouldn't we be testing these therapies early on? And of course, we cannot wait to see whether that can improve the outcomes. However, we have pretty well established surrogate imaging markers. For example, progression of left ventricle hypertrophy, increase in the LV size, impairment in the diastolic dysfunction, and endothelial dysfunction. So I truly look forward to some of these innovative medical therapies being tested, and I hope that in the next 5 years we'll have some more better answer in saying, if you have this condition, this is the time you should start screening. Maybe early statin would work. And if you have any of these structural abnormalities, maybe trying these novel therapies can help reduce the progression of the disease. So I think so the time is now. We really need to learn a lot.
Yeah, absolutely. And then there's a question directed to you specifically, Tammy. Have you noticed any improvement in any aspect after your procedures?
My energy level went up quite a bit after I had that procedure done. I mean, I'm a full-time working nurse. I'm at bedside most of the time. So, I mean, would say my energy, I just felt a lot better. I could tell that I just, and I would say not, I don't want to say brain fog, but it just felt like I was, maybe my blood flow was better or something, I don't know, but it just, I felt better. I just had a lot more energy.
Yeah, I would imagine so. So just to clarify, so Tammy had a very severe narrowing of her left anterior descending artery. So there was a really reduced flow to the front of her heart, which we think is probably one of the most important areas of the heart, and the left ventricle as far as its function is concerned. So it's not surprising at all that you were feeling tired, short of breath, and having chest pain. And so I think it's just fortunate that everything sort of worked out the way it did, that we were able to identify these things. So I want to shift gears a little bit and talk about the brain, because I think that this is another area that's really critical that we address when we talk about acquired cardiovascular disease. And this is something that we addressed very early on with you, Tammy, and that is that a lot of our coarctation patients are at risk for having bleeding in the brain as a result of having aneurysms in the brain. And I don't know that we fully understand this yet. Again, I think it probably comes back to some sort of molecular biological abnormality in patients who have coarctation of the aorta that tends to cause them to have an aneurysm in the brain. And the current recommendations are, of course, that all patients with coarctation should have some sort of brain imaging to evaluate the vessels of their brain and prove that there isn't an aneurysm once in their lifetime. And if that's not there, then that's enough. We don't need to do any further evaluation. But I think we should probably move on and actually talk about what's called ischemic stroke, which is where there's a reduction in the blood flow to the brain causing a stroke from that standpoint. So in other words, we're separating the hemorrhagic stroke, which you see on the left side of the screen, and then the ischemic stroke, which is what you see on the right side of the screen. So Dr. Nasir, talk to us about what are the things that we have to worry about that sort of predispose our patients to ischemic stroke from what we know so far in the data.
So a couple of things. One is definitely hypertension and the increase in the pulse pressure, especially in the small vasculature in the brains, can precipitate smaller strokes, the Leukener strokes. So these are, studies have clearly shown that if you do a brain MRI or a CT, you are going to find more incident silent strokes in these individuals. Now, is that a combination of the plaque buildup that may cause some reduction in the blood flow, or is this related to long-term hemodynamic changes that happen, and especially related to hypertension? It's unknown. Now, one of the challenges with this is, as these individuals are going to live longer, the risk of Alzheimer and dementia definitely increase, at least what we know from prior studies in the general population, folks having those silent strokes. So of course, as you pointed out, aneurysm remains a big challenge. Thankfully, I learned today that you may not need to have much more repeated scans, so that's good news.
At least that's based on
guidelines.
Yeah.
So that's good news. But definitely the risk of, with this hypertension and instability, with the hemodynamically instability, makes small silent Leukener strokes more frequent. Now, what's the answer? I don't have. I would say the best suggestion, again, more aggressive risk factors reduction, trying to be on top of the blood pressure as much as possible, which, by the way, I'm sure you would know that it can be extremely challenging in these patients, especially with the wide pulse pressures. And most of the evidence that at least we know early initiation of statins, especially in lowering the cholesterol as much as possible. So yes, two front challenges that happens, not only plaque buildup in your heart arteries, affecting your larger vessels, aneurysms, but also affecting the very small blood vessels in the brain, causing silent strokes and putting you at risk for long-term Alzheimer and dementia.
Yeah, I think those are both really important points. And then I think I want to sort of dig a little bit deeper into that, and that is the whole issue with the coarctation at the end of the day is that the ascending and the arch of the aorta has quote-unquote normal flow, and then there's the coarctation, which is the narrowing after the arch. So the arch is the part where the blood vessels come off of to give rise to the blood flow to the brain. And then after that, you have the obstruction from the coarctation, which basically means then that the body does everything it can to really ramp up the blood pressure, especially the kidneys, to ramp up the blood pressure downstream of the narrowing, which then means that it overcompensates by increasing the pressure in the first part of the aorta, including the arch, including the vessels that go to the brain. So there's almost an exaggerated amount of high blood pressure going to the brain, which is why we sort of get into this problem. So I do think, I agree with you. I think that this is going to be something that we're going to have to spend a lot of time as a community starting to think about, and that is how do we really optimize the brain health for patients, not only with coarctation but also with congenital heart disease in general, because I think we just haven't gotten there yet, right? I mean, I think because our populations are just getting to the age where we start to see these things, I think we haven't figured this out yet. But I also think, there's also some data that suggests that outside of coarctation patients, that a lot of our shunt patients are the ones who end up developing strokes. And unfortunately, that can be related to their surgical repair time, that there was some sort of clinically, in other words, an asymptomatic event during the surgical repair or during the catheterization repair, because sometimes that happens. Then, of course, unfortunately, our patients go through a lot, and so sometimes something can come through the IV, or air can come through an air bubble can come through the IV, and that can go through the shunt inside the heart and then go to the brain. So I think this is an area that really requires a lot more study.
And what's your thoughts on the risk of strokes for patients requiring pacemakers and ICDs?
That's a real challenge. So actually, there was a question yesterday on that specifically. So what Dr. Nasir is talking about is, when we put a pacemaker in a patient, there's two wires typically, especially for our young patients, one that sits in the right atrium and one that sits in the right ventricle. And those wires that sit there can potentially have tiny little mini clots that form on them. And then if you happen to have a shunt, such as an atrial septal defect, in other words, a hole in the upper chambers of the heart, or a ventricular septal defect, which is a hole in the bottom chambers of the heart, any tiny clots that sit on those wires can potentially travel through that hole and then go to the left side of the heart and then be propagated to the brain or the heart. And so there's some controversy. We don't really know this because there isn't a lot of data about it, but most of us feel like if you're going to go ahead and put pacemaker leads in the heart, that you should probably make sure that you address the atrial septal defect before you put those leads in the heart. I think the VSD, the ventricular septal defect, idea is still, you treat the ventricular septal defect that needs treatment. I don't know that people preemptively close every single tiny ventricular septal defect that they're going to put a pacemaker in. I think outside of that, I don't know that we know a whole lot more or have any other ideas for how to manage that.
So, Tammy, I'm sure you have dealt with a lot of the kids, adolescents, and their parents. What are the major concerns and challenges as they move from adolescent to an adult? And what have they shared with you?
Compliance. A big thing with compliance. When they get to be teenagers, they don't want to do their meds. They don't want to, they don't, compliance is huge. The other thing is just health factors, eating healthy, exercising, everything that we should do. I think younger people now are better at it than my age group is, but they still want to be like their peers and go eat pizza every night, or go to McDonald's. They would bring McDonald's in, we would go, but it is what it is. They want to be normal. They want to be, and that is a big thing for them. They don't want to sit there and say, "Oh, I got to take these meds,"
Yeah.
And I think compliance, and then the parents just, are they going to be able to be normal? Are they going to be, and I think you're seeing a lot now, as you know, with having the three. With the hypoplast and stuff, these kids are living now. They are getting older. They are getting older and stuff. So you're going to be seeing a lot of those in the community.
Yeah. I think you just raised a really interesting point, which is that some of our single ventricle patients who have gone through 3 cardiac surgeries, mandatorily at least 3 cardiac surgeries in their early childhood, we almost overcompensate for them. I don't know if you've ever experienced this. So many of our children's hospitals have a McDonald's and a Dairy Queen and a Burger King and and a Pizza Hut. At least at St. Louis Children's, I loved the Pizza Hut because I could get a personal pan pizza at lunchtime whenever I wanted to, right? And I think unfortunately, we worry so much about these kids being so cachectic early on, and we need them to gain weight in order to successfully make it through all these surgeries. That I think we overcompensate, and then when they get to adulthood, it's very hard to pull back on that. And I think that's exactly, you're absolutely right, Tammy, about that. So, if you've been sending them to McDonald's all their entire lives, whenever they go to the children's hospital, it's hard to say when you hit your 20s you should stop going to McDonald's, because that's what your parents and your doctors have been telling you to do the whole time.
Or bringing the ice cream.
Or bringing the ice cream. Right, exactly. So, I don't want to blame our pediatric colleagues for that, right? I think, we need to do everything we can to get those kids to adulthood. So I think it's incumbent upon us to start having those conversations early on about what healthy eating looks like. And I will make a plug that's exactly what our conversation tomorrow night at 5 o'clock is going to be about. So we have 2 very special guests who are going to tell us a little bit more about what healthy eating looks like. So we have another question that came in, and that is there a standard age range to be screened?
So, great question. No right answer. For adults without congenital heart disease, usually the screenings recommended, you can start at anywhere above age 40 and above. Of course, that is for the imaging, but the screening for cholesterol can happen even in your 20s. That needs to happen. The HbA1c, the sugar should be at least checked every 2 to 3 years. The kidney function, of course, screening for the weight, and all of those. Counseling for cigarette smoking needs to happen. We definitely need
vaping.
And vaping is another
Vaping
one
is a big
that's
problem
critically
today.
important. Counseling on healthy diet is, as we just pointed out, that should happen at each visit, absolutely. But in my opinion, if you're screening for atherosclerosis, I think so we can get it started in the 30s. We may have to screen maybe a few more individuals to find those who may have some early plaque buildup, but I think so it's worth the effort, because if you can find and initiate those aggressive therapies, you can definitely reduce the trajectory of their, I would say, accelerated atherosclerotic disease and the complication that comes along with this, like blocked arteries, stable CAD, aortic plaque ruptures, and stroke, which is for the long term is going to be high. So I think that's where I would consider early 30s, definitely screen for CAD and plaque buildup.
And so this last question I think is really for both of you, because I think Tammy's lived it. Hopefully Dr. Nasir, you won't live this. But so where would someone get started if they think they are seeing early signs?
Me personally, I just was not feeling well, so I went to my PCP, and they said, let's just go ahead and send you to a cardiologist. And that's where you start. Start with your PCP, get some labs done, get an EKG, start there.
I think the key element that you said that you have a PCP,
I was gonna
which
say
unfortunately I don't actually have one, so apologies to everybody. But I think that's a great suggestion. Dr.
Well,
Nasir.
same here, make sure you have your PCP. I truly think that seeing an adult congenital heart disease specialist is critically important as soon as you hit adulthood. Now, depending upon what underlying condition, how often they need to be screened, needs to happen. But I think if we can come up with some simple protocols of when to check their cholesterols, what to do with that, diabetes, how to counsel them on their diet and exercise, and when to screen, I think so that can at least help streamline the process, where a lot individuals may not fall through the crack. But again, the issue here, Tammy and Dr. Lynn, is that we don't have true evidence, because we have never had an opportunity to really study this in depth. And I think so that is going to be critical, because these are key societal issues and questions and important, and hence I commend you on the PCORI effort again, which I think that bringing in stakeholders like you and everyone else who can come and speak about what are the needs and with your guidance, hopefully we can generate the evidence.
Well, thank you. So there are a couple topics that we didn't get a chance to talk about tonight, and I think we broached them briefly, and that is heart failure, which we will address on Saturday. We'll have an entire session on Saturday's symposium about heart failure and adult congenital heart disease. And then the other topic, which we did talk about a little bit last night, and that is arrhythmias that arise as an acquired fashion in congenital heart disease. And we'll talk a little bit more about that on Saturday as well. We'll have a whole session about arrhythmias in congenital heart disease and how to dissect out whether it's related to the structural issue from the congenital heart disease or it's a primary arrhythmia issue. So it's been fantastic having all of you. We've had a really excellent discussion, and Tammy, thank you so much for being here. We've learned so much from your experience, both as a patient as well as a healthcare provider. It's been fantastic. And Dr. Nasir, I want to thank you for your wisdom as well as your experience and your input from your scientific background. So it's been a great session today, and we welcome you back tomorrow, where we're going to be talking about healthy eating in adult congenital heart disease. Don't miss that. It'll be fantastic. And then on Friday, we're going to have a special episode in Spanish. So join us for both those episodes, both at 5 p.m. here on the DeBakey channel. Thanks for joining us.